Hello, and welcome to the American Lung Association Cessation Medication Overview Training. The American Lung Association's signature program, Freedom from Smoking, is an evidence-based program that has proven to help people quit smoking. Counseling helps you learn techniques for preparing to stop smoking and provides support for you during the process. With that being said, combining medications with behavioral counseling provides the best chance for establishing long-term smoking abstinence. Today we will do an overview of the 7 FDA-approved tobacco cessation medications. It is important to know that when advising patients and clients on medications, that you make sure that you talk with their primary care physician. As outlined in the U.S. Department of Health and Human Services Clinical Practice Guideline, Treating Tobacco Use and Dependence, 2008 update, and supported as a best practice by CDC and other leading agencies, including the American Lung Association. Combination of both cessation counseling plus medication or nicotine replacement therapy is a best practice for going smoke-free. We know from our own metrics that approximately 60% of smokers succeed in quitting tobacco when our Freedom from Smoking program is paired with the use of NRT, compared to only 13 to 17% of those who are successful going it alone with counseling only. Although Freedom from Smoking provides the information you need to give a brief overview of all FDA-approved medications to help participants decide which option may be the best for them, today we will review a more in-depth approach to advising participants on proper use of pharmacotherapy. Studies suggest that all people trying to quit tobacco should use effective medications, except under special circumstances, people who smoke less than 10 cigarettes per day, adolescents under 18 years of age, pregnant or breastfeeding women, and people with certain medical conditions. People who use medications in addition to behavior modification counseling to quit tobacco may double or possibly triple their quit rate. It is important to refer participants to their primary care physician regarding dosage. Many misuse NRT and perhaps have too high of a dose or too low and find they don't work because of misuse. As you know, there are both prescription and over-the-counter pharmacotherapy options, 5 that contain nicotine and 2 that don't. Since the majority of your questions will be about those products that do contain nicotine, we will be reviewing those aids, the nicotine patch, gum and lozenge, nasal spray, and inhaler a little further. Then we will briefly review the prescription non-nicotine medications, as these medications would be advised solely through their primary care physician. Nicotine replacement medications deliver nicotine to the body differently than cigarettes. This can result in a slower delivery of nicotine and in lower nicotine levels in the bloodstream. With these medications, nicotine is absorbed either through the skin with patches or through membranes in the nose or mouth, which is the gum, inhaler, spray, and lozenge. It is absorbed slowly and transported to the brain in smaller, even doses. This means that there will not be the same immediate feelings of reward that was part of a smoking or chewing tobacco. But there is enough nicotine in the replacement products to calm sensations of withdrawal. This graph from the Mayo Clinic shows how the use of these medications can reduce the recovery symptoms experienced by the quitter. The yellow area shows the recovery/withdrawal symptom. As you know, this peaks in intensity through the first few days. The red lines represent the urges and cravings that are experienced. You can see that those urges become less frequent and less intense as days go on. The green lines represent the NRT. The large green area shows a long-release NRT, such as a patch, and the smaller green bumps represent immediate-release NRT, such as the gum, lozenge, nasal spray, or inhaler. Many people ask which of the 7 FDA-approved cessation medications are the most effective. My short answer is whichever one works best for the participant and provides minimal side effects. My research-based response would be to share this graph with you. Take time to look at the confidence intervals that are highlighted in yellow. All of these estimated abstinence rates are for monotherapies. On the next slide, we will be looking at the estimated abstinence rates for combination therapy, so keep these numbers in mind as we move to the next slide. As you can see in this table, combination therapy is shown to prove the highest abstinence rates of all. These rates are higher than the numbers that were listed on the last page for monotherapies. So what does this research tell us? Combination therapy has proven to work the best for individuals quitting tobacco. For example, if you combined a long-acting NRT such as the patch with a short-acting NRT such as lozenge, the patch will provide the individual a steady nicotine level throughout the day, and the lozenge will allow patients to respond to urges with a short-acting NRT. Patients can also use NRT along with bupropion SR. Varenicline plus bupropion SR is not normally used, and since both of these medications are prescription, participants should check with their primary care physician. Varenicline plus NRT is not recommended but can be used if patients prefer. It is also important to note that monotherapy with short-acting NRT, such as gum or lozenge, should be rarely used. Later on in the training, we will be reviewing all of these medications, which will assist you in better understanding these combinations. Most individuals want to stop NRT too soon. So how long should you advise participants to use NRT? In a research clinical trial, 1,504 smokers participated in a research clinic. They received 1 of 6 treatments for 8 weeks, as you can see in the table on this slide. In addition to receiving pharmacotherapy treatment, they also participated in 6 brief counseling sessions. When looking at this table, you can see the difference from initial cessation and abstinence at 1 week, 8 weeks, and 6 months. From this table, we are able to see that abstinence at 6 months was more prevalent. We cannot predict who will have better outcomes with longer treatment, but nicotine patch therapy for 6 months outperforms a standard 8-week course treatment. Do your participants adhere to the NRT treatment guidelines? Only 28.6% of NRT users completed the recommended 8 weeks of treatment. Most quit prematurely because they believed the medication was not working, had unwanted side effects, or believed that they no longer needed treatment. It is important to find the correct dosage of NRT that will work for each participant. Kate will now be reviewing with you the different options that are available over the counter as well as prescription.
We will now review the over-the-counter nicotine replacement therapies that contain nicotine. We always advise that individuals talk with their primary care physician about taking any medication, whether over-the-counter or prescription. The first NRT we will review is the nicotine patch. This product is available in 21, 14, and 7 milligram doses. As you can see by the pictures, depending on which brand they get, it could be clear or nude colored. They will use 1 patch every 24 hours and rotate between 2 different locations on their body every other day. This will help reduce with any skin irritation. They will also want to pick a location on their body that has minimal sweat and hair, such as the shoulders or hips. It is not recommended for the hands or bottoms of the feet, and they should apply it at least 3 hours before or after a shower. This will ensure that it adequately adheres. If they do experience irritation from the adhesive, they can switch the location of the patch and use an alcohol swab on the areas that are affected. This product is recommended for overnight use, although if they do experience vivid, strange, or unusual dreams, they could try applying the patch earlier in the day. We will now review monotherapy dosing for the nicotine patch. To determine which patch level to start an individual on, you will want to assess how many cigarettes and/or nicotine they are currently consuming. For instance, 1 cigarette is equal to 1 milligram of nicotine. So an individual smoking a pack of cigarettes a day, about 20 cigarettes, is consuming about 20 milligrams of nicotine per day. You will want to start this individual on the 21 milligram patch and monitor their withdrawal symptoms and urges. You can see on this slide the number of cigarettes per day, or CPD, and how that equivalates to the milligram patch dose to start them on. You will then want to adjust this dosage up or down based on the withdrawal symptoms and urges the individual is experiencing. After 4 to 6 weeks of smoking abstinence, you can begin to taper the milligram patch dosage while continuing to monitor the individual's withdrawal symptoms. For individuals with higher nicotine dependence, it is recommended to have them on each milligram dosage step for a minimum of 6 weeks, as well as recommending they contact their primary care physician. You can see here the recommended dosage for smokeless tobacco users as well. For reference, 1 can of smokeless tobacco is about equal to 4 packs of cigarettes, or 80 milligrams of nicotine. Also, just one note to make is that this is based on cans or pouches per week, not day, as we had calculated with the cigarettes per day. So if an individual is using 1 can of smokeless tobacco a week, they are consuming about 4 packs of cigarettes a week, or about 11 cigarettes per day. You will want to start this individual on the 14 milligram patch and monitor their withdrawal symptoms to determine if they need a higher or lower patch dose. Again, you will want to taper after 4 to 6 weeks and continue to monitor their withdrawal symptoms. The next NRT we will review is the nicotine gum. This is available in 4 and 2 milligram doses, as well as a variety of flavors, such as mint, cinnamon, which creates heat and can help curb cravings, as well as fruit flavors. This product is best when used in combination with the patch, as it can help with breakthrough cravings, as mentioned on a previous slide where we reviewed the Mayo Clinic cravings graph. You will want to advise the individuals on how to use this product correctly, as you do not chew it like a regular piece of gum. This is why it is not recommended for avid gum chewers or individuals who like to chew gum. They will want to bite down on the gum till the coating is broken, and then park it between their cheek and gum. This will ensure that the nicotine is absorbed into the lining of their mouth and their bloodstream instead of being swallowed and end up in their stomach. If an individual is complaining of heartburn or nausea, they may be using it incorrectly, and it may be best to switch them to the lozenge. They will also want to wait 30 minutes before or after drinking acidic beverages to use the gum to ensure proper absorption of the nicotine. Lastly, this product can be used intermittently with the lozenge, which we will review on the next slides. When it comes to monotherapy dosing for the nicotine gum, you will want to base the milligram dosage on when the individual has their first cigarette for the day or how many cigarettes they smoke a day. This will help indicate the nicotine dependence level of the individual. The sooner they need a cigarette when they wake and the more cigarettes they consume in a day indicates a higher level of nicotine dependence. So an individual who smokes their first cigarette within 30 minutes of waking or consumes more than 20 cigarettes a day will have a higher dependence than an individual who can wait 30 minutes or longer and consumes less than 20 cigarettes a day. For individuals with a higher dependence, you will want to start them on the 4 milligram dosage, and individuals with a lower dependence will want to start with 2 milligram dosage. Initially, they will want to use 1 to 2 pieces every 1 to 2 hours and up to 10 to 12 pieces a day. Taper the individual as tolerated while monitoring their withdrawal symptoms. This product is not recommended for smokeless tobacco users. The last over-the-counter nicotine NRT that we will discuss is a nicotine lozenge. This product is similar to the nicotine gum and comes in 4 and 2 milligram doses, as well as a variety of flavors such as mint and cherry, as well as a mini mint, which is recommended to minimize the side effects. This product is best when used in combination with the patch as well to help with breakthrough cravings. You will want to advise individuals on how to use this product correctly, and it is recommended, and this product is recommended for gum chewers. They will want to suck on the lozenge and then park it between their gum and cheek, similar to the gum. And again, this will ensure that the nicotine is absorbed into the lining of the mouth and then bloodstream instead of being swallowed and end up in the stomach. Again, if they're complaining of heartburn or nausea, they may be using the product incorrectly. They will also want to wait 30 minutes before or after drinking beverages to use the lozenge to ensure proper absorption of nicotine. And lastly, this product can be used intermittently with the gum, as mentioned before. The monotherapy dosage for the lozenge is the same as the dosage for the nicotine gum. This product, however, is recommended for smokeless users. For individuals with a higher nicotine dependence level, such as 3 or more cans a week, you will want to start them on the 4 milligram dosage as compared to those who use less than 3 cans a week, who will want to start at the 2 milligram dosage. Again, you will want to adjust the milligram dosage based on the individual's withdrawal symptoms and cravings. We will now review the 2 prescription nicotine replacement therapies. Again, we always advise that they talk with their primary care physician about taking any medication, whether over-the-counter or prescription. We will first review the nicotine inhaler. As mentioned, this product needs to be prescribed by a physician. You can see in the picture that what the inhaler looks like. There is a mouthpiece, the cartridge, which contains the nicotine, and then the end cap. The individual will insert the cartridge and the end cap will pierce it, and then they can puff on the mouthpiece end. Once the cartridge is empty, they can replace it with a new one. Each cartridge contains about 10 milligrams of nicotine, although only about 4 milligrams is delivered, and of the 4 milligrams, only 2 milligrams is absorbed through the lining of the mouth. So each cartridge is approximately equivalent to 2 cigarettes. One cartridge lasts about 20 minutes of active puffing or 4 uses at 10 minutes per use. It is recommended to keep the inhaler above 60 degrees as cold temperatures reduce the amount of nicotine inhaled. There is a link here where you can download more information to give to individuals. When it comes to dosing for this product, it is recommended that an individual use a minimum of 6 cartridges a day, up to 16 a day. You will want to monitor their withdrawal symptoms as well. This product can be used in combination with the patch, gum, and/or lozenge, which we will review in an upcoming slide. Again, they will need to talk with their primary care physician to get a prescription for this product. Lastly, this product is not recommended for smokeless tobacco users as it closely mimics smoking a cigarette. The last prescription NRT we will review is the nicotine nasal spray. Again, this product is by prescription only, so the individual will need to talk with their primary care physician. Each 10 milligram spray bottle contains 100 milligrams of nicotine and approximately 200 sprays. So that equates to one spray equal to half a milligram of nicotine. It is recommended to spray one spray in each nostril every hour, which will equate to 1 milligram of nicotine or one cigarette. When using this product, the individual will want to tilt their head back slightly as the medicine is sprayed into their nose. They will want to be careful not to sniff, swallow, or inhale the medicine. If their nose starts to run, they will want to gently sniff to keep the medicine in their nose and wait 2 to 3 minutes before blowing their nose. This is similar to if they were using a saline or allergy nasal spray. Again, there is a link here that you can download more information to give to individuals. Recommended dosing for this product is again 1 spray per nostril, 1 to 2 times an hour, up to 5 times an hour, and not to exceed 80 sprays a day, which is equal to 40 milligrams of nicotine. You will want to monitor their withdrawal symptoms as well. Again, they will need to talk with their primary care physician to get a prescription for this product. This product is not recommended for smokeless tobacco users either. We will now talk about how to use these nicotine replacement therapies in combination with each other. Combination therapy, or providing 2 types of delivery of the nicotine delivery system, 1 or 2 long-acting medications, and 1 or more short-acting NRTs, appears to be more effective. This should be considered for those who have failed monotherapy in the past and those considered highly tobacco dependent, although anyone going through a clinic can benefit from combination therapy. To start, you will want to dose the long-acting medications, such as the patch, based on the number of cigarettes consumed per day as described in the previous slide. You will then want to dose the short-acting medication, such as the gum, lozenge, inhaler, or nasal spray. This will be based on personal preference and if the inhaler or nasal spray can be prescribed by the primary care physician. The short-acting medication will be used every 1 to 2 hours as needed when breakthrough withdrawal cravings occur. You will want to monitor the individual's withdrawal symptoms and adjust the patch dosage accordingly, such as needing short-acting medicine more frequently, then they may need a higher dosage of the patch. The overall goal is to minimize the need of the short-acting medicine. Taper as tolerated and monitor their withdrawal symptoms. These same guidelines can be used for individuals who use smokeless tobacco. This strategy is endorsed by the 2008 Public Health Service Clinic Practice Guidelines, but is considered off-label prescribing according to the FDA-approved product labels. Chelsea will now go through a few case scenarios to further demonstrate how to dose an individual.
Again, we will now go through a few case studies to practice what we have learned about each nicotine replacement therapy. Our first case scenario has patient Dave Herb, who smoked 25 cigarettes per day. He would like to quit on Tuesday, September 17th. Outlined on the right is an example of a treatment plan that you could provide David for his physical challenges that he will experience during his quit attempt. From Tuesday, September 17th to Monday, October 28th, you would recommend that David use 21 milligram nicotine patch for 6 weeks. Again, apply 1 patch at least 3 hours before or after a shower or workout for 24 hours, and then rotate between 2 different locations each time. In addition to the patch, you would recommend that he use a 2 milligram nicotine lozenge for every breakthrough craving, 3 times per day or as needed. Make sure to not drink anything acidic, such as orange juice, coffee, iced tea, a half hour before using a lozenge. On tougher days, David could definitely use the lozenge more than 3 times per day. It is important to also drink plenty of water and green tea throughout the day to release toxins and chemicals. From Tuesday, October 29th, to Monday, December 9th, David can begin using a 14 milligram nicotine patch for the next 6 weeks. Again, he will apply 1 patch for 24 hours and rotate between 2 different locations every day. In addition to the patch, he would use the 2 milligram nicotine lozenge for the breakthrough cravings 3 times per day as needed. Again, making sure to not drink anything acidic such as orange juice, coffee, or iced tea a half hour before using the lozenge. Again, increasing the amount of the lozenge on tougher days. From Tuesday, December 10th to Monday, January 20th, David can begin to use a 7 milligram nicotine patch for the next 6 weeks, applying the 1 patch for 24 hours and rotating between 2 different locations every day. In addition to the patch, he will continue to use the 2 milligram nicotine lozenge for every breakthrough craving 3 times per day as needed, and making sure to not drink anything acidic such as orange juice, coffee, or iced tea a half hour before using the lozenge. Again, on tougher days, he can begin to use more lozenge if needed, making sure at this point not to exceed 5 total pieces per day. From Tuesday, January 21st to Monday, March 3rd, David can use 2 milligram nicotine lozenge for the next 6 weeks, only for breakthrough cravings as needed, making sure not to drink anything acidic. It is important to remember to not stop treatment early, only discontinue use once you experience no urges or cravings for a total of 14 days consecutively while using nicotine patches or gum. Our second case scenario is Rhonda Robinson, who smokes 20 cigarettes per day. She would also like to quit on Tuesday, September 17th. For the first 6 weeks, you would recommend that Rhonda also use the 21 milligram nicotine patch. Again, applying 1 patch at least 3 hours before or after a shower or workout for 24 hours and rotate between 2 different locations each time. In addition to the patch, using a 2 milligram nicotine lozenge for every breakthrough craving. Making sure to not drink anything acidic a half hour before using the lozenge. And on tougher days, Rhonda can use this lozenge more than 3 times a day. During the second 6 weeks, Rhonda can begin using a 14 milligram nicotine patch, as well as a 2 milligram nicotine lozenge for the breakthrough cravings. During the third 6 weeks, Rhonda can begin using a 7 milligram nicotine patch, as well as a 2 milligram nicotine lozenge for the breakthrough cravings. The last 6 weeks, Rhonda can go down to just using the 2 milligram nicotine lozenge for breakthrough cravings as needed. Again, also remembering that it's important to not stop treatment early and only discontinue use once there is no urges or cravings for a total of 14 days consecutively when using the nicotine patches or gum and lozenge. The last case scenario is David Powell, who smokes 9 to 10 cigarettes per day. He would also like to quit on Tuesday, September 17th. For the first 6 weeks, you would recommend that David use the 7 milligram nicotine patch, again applying 1 patch for 24 hours and rotating between 2 different locations each time. In addition to the patch, David would use a 2 milligram nicotine lozenge for every breakthrough cravings 3 times per day as needed. During the second 6 weeks, David can use a 2 milligram nicotine patch for those breakthrough cravings every 3 to 4 hours or as needed, up to 5 times per day. Third 6 weeks, David can continue to use the 2 milligram nicotine patch every 4 hours or up to 4 times per day. And then the last 6 weeks, David can continue to use the 2 milligram nicotine lozenge every 5 hours or up to 3 times per day. Again, always remember that it is important to not stop treatment early and only discontinue use when you are no longer experiencing any urges or cravings for a total of 14 days consecutively. Now that we are done reviewing case scenarios, I'm going to pass it back over to Kate.
We will now briefly discuss the prescription nicotine replacement therapies that do not contain nicotine. Participants will have to talk with their primary care physician about getting prescribed these medications. The first prescription NRT we will review is bupropion, or also known as Wellbutrin. This is an antidepressant and should be used a minimum of 2 weeks prior to quitting to give the medication enough time to be at its full effect on quit day. It has been known to help with irritability when quitting as well. Dosing for this medicine will depend on their physician's recommendations, although it is typically dosed at 150 milligrams once or twice per day. The next prescription NRT we will review is varenicline, or more commonly known as Chantix. How this medication works is by blocking the receptors in the brain to prevent nicotine from attaching and releasing dopamine. This medication also has the highest stay-quit rate at 44% after 6 months out of all the 7 FDA-approved medications. Individuals will start with a starter pack 7 days prior to their quit day. The start pack consists of the individual taking 1 pill in the morning for the first 3 days. After that, the individual will take 1 pill in the morning and 1 in the evening for the next 4 days. Then, on day 8, they will quit using tobacco and continue taking 1 pill in the morning and 1 pill in the evening. Individuals should eat something before taking the medication as well. If nausea does continue or happens, FDA does approve cutting the dosage and taking 1 milligram dose cut in half twice a day, although they will want to talk with their primary care physician about this. It is recommended that individuals take this medication a minimum of 3 months and maximum of 12 months, with 6 months being the most effective. Let's discuss a few lessons learned when advising individuals on nicotine replacement therapy. When advising individuals on NRT, there are a few things to keep in mind. All individuals should use NRT for at least 12 weeks. Combination therapy is recommended, so using a longer-acting NRT such as the patch and a short-acting NRT such as the gum or lozenge together. You may want to consider higher dosages of NRT for individuals who are higher nicotine-dependent individuals. Also, individuals who are at risk of relapse should use NRT for 6 or more months. Some examples of these individuals are individuals with persistent or strong urges, higher dependence individuals, those with comorbid medical and or psychiatric illnesses, those with past substance abuse, and those who are unable to quit on their target quit date. I will now turn it back to Chelsea.
To close out this training, we would like to tell you about the resources that we have available to assist you in providing tobacco cessation in your community. The American Lung Association in Pennsylvania has the above one-pager available that describes all of the various tobacco cessation methods that are available. On this one-pager, we have our signature program, Freedom from Smoking, which is offered as an in-person clinics as well as electronically through Freedom from Smoking Plus. We also have our Freedom from Smoking self-help manual that is available for individuals who are looking to quit on their own. Information about the PA-Free Quit Line is also listed on here as a resource. The PA-Free Quit Line is a local resource for quitting smoking. It provides over-the-phone counseling services with certified quit coaches. Nicotine patches and lozenges are also available for qualified callers, and support for all PA residents. At the bottom of the page, you will find contacts for all the local cessation programs that are available in PA-Free through funding provided by the Pennsylvania Department of Health. If you are interested in the above tobacco cessation referral, please contact your local American Lung Association in PA office. The American Lung Association in PA has a lot of resources available that help promote various cessation programs. On this slide are examples of materials that we have available from the CDC TIPS campaign. These materials promote the PA Free Quit line. We also have a pregnancy flyer and packet that promotes the incentive program that the PA Free Quit line offers to pregnant women. Feel free to reach out to us today to place an order of these materials to be shipped to your location. For more resources, visit the Pennsylvania Department of Health Tobacco Prevention webpage and click on PA Free Quit line for more information. For more information on providing brief interventions, how to enroll in tobacco cessation program, or how to be trained and certified to lead freedom from smoking programs in your areas, we encourage you to visit our website, lung.org or lung.org/freedomfromsmoking, or call us at 1-800-LUNG-USA. Thank you for taking the time to listen to our advising participants on pharmacotherapy training. If you have any questions, please use the above contact information to reach out. Thank you.